The following podcast is part of a certified educational activity titled Maximizing Therapeutic Innovations in Bladder Cancer, Expert Strategies for Comprehensive Care Across Disease Stages. Access the entire activity and complete the post-test at peerview.com/STT860. Downloadable slides and practice aids are also available.
I'm pleased to be joined today by two esteemed friends and colleagues, Shilpa Gupta from Cleveland and Sia Danishmand from USC Los Angeles. So today we will span across the entire spectrum of urothelial cancer management, starting from the very early stage up to the metastatic stage, looking for the innovations and the way forward and the new opportunities for the patients. So the goal of today's meeting are to improve your knowledge, if possible. I'm sure that you have already pretty well experienced and pretty much aware of the movements that are around the bladder cancer management today, but making you equipped and skilled on how to best manage the new options for therapy with regards to efficacy, but also safety. We will also discuss around this across the disease stages, curative setting and metastatic setting, and provide you with kind of guidance on how to best deal with the patient. We will present patient cases throughout the session, throughout the symposium, looking at the most representative case that may come to your office for possible management. So I'm sure you will enjoy this discussion. Having said that, don't miss the opportunity to visit the BCAN website, whereby you can be able to look at the comprehensive support for patients with bladder cancer across the entire spectrum of opportunities and needs for patients with regards to trial availability, with therapeutic availability in general, support and material, educational material. From the other side of the Atlantic, we can take advantage of the huge activity of the World Bladder Cancer Patient Coalition, which is incorporating and coagulating all the national European patient advocate groups. It's a very granular distribution across the European countries, and in the website actually provides the patient surveys and the patient journeys throughout the disease course and their therapeutic course. It's interesting to see. It's interesting to look at the website also when looking at the patient possibilities and the patient needs also from this side of the Atlantic. So going in detail on the needs for the patients with bladder cancer, there are so many unmet needs today. That starts from the availability and access to the standard of care therapy. And I mean BCG therapy for non-muscle invasive disease. It is still problematic in certain geographical areas. Radical cystectomy, we will discuss quite a lot today, I suspect, with the colleagues around the radical cystectomy issue, which is still an issue for non-muscle invasive disease and muscle invasive disease, and access to the most advanced therapeutic options for metastatic tumors. So we'll discuss with Shilpa what is going on in metastatic setting, and access to treatment is still problematic for a number of reasons for patients with bladder cancer. So we'll have a special focus on these unmet needs. And let's start with the first session. I am pleased to introduce Sia Danishmand, the professor of urologic oncology at USC Norris Comprehensive Cancer Center in Los Angeles, California. So please, Sia, the floor is yours.
Thank you so much, Andrea. So we're going to talk about non-muscle invasive bladder cancer, specifically high risk NMIBC. This is snapshots of what's going on and for treatment approaches. There's lots of different types of treatment approaches involving immune checkpoint inhibitors. There's gene therapy. There's intravesical drug delivery systems with the Sunrise. There's IL-15 superagonist. FGFR3 inhibitors coming through, some ADCs actually in early phase studies. And then we have the phase 3 studies with cretostimogene, which is another sort of viral vector-based therapy, and some other activity. And of course, gemcitabine docetaxel, which has been the go-to drug combination for high-risk non-muscle invasive bladder cancer outside of clinical trials. So as you can see, there's lots going on, which is exciting for patients and providers as well. So let's start with immunotherapy for BCG unresponsive high-risk non-muscle invasive bladder cancer. This was the keynote study, the 057 cohort A, which included patients with CIS with or without papillary disease. So this high-grade T or T1. So you can see the CR rates there was 40%, non-CR rates of 60%, but no one progressed to T2 disease. But when you extended the follow-up out, the response rates go down quite a bit. This was the first drug approved after valrubicin. It was FDA approved for the treatment of BCG unresponsive disease and CIS with or without papillary disease. But again, we're risking some systemic side effects with very limited efficacy, especially when you go out to 2 years with this drug. So what's next? We do have combination therapies with investigational immunotherapy strategies for BCG unresponsive and BCG naive patients. As you can see, there are a number of trials. I'm not going to go through all of them in great detail, but just to show you that we're trying to improve the efficacy of BCG by adding a checkpoint inhibitor to BCG. Actually, I had an interesting call from a medical oncologist who was concerned about adding immunotherapy to BCG because BCG is an immunotherapy drug essentially. I had to remind him that we actually have 5 or 6 trials in this space combining the two. So from a safety perspective, absolutely safe to do. BCG works locally. Obviously, the mechanism of action is completely different with systemic checkpoint inhibitors. But you can see the different sort of trials in the space with combination therapy of BCG plus a checkpoint inhibitor. So what about gene therapy? So nadofaragene firadenovec is a non-replicating adenoviral vector gene therapy. It delivers the alpha interferon 2b into the urothelial cells, and the urothelial cells end up shedding essentially this interferon alpha 2b, which is then transcribed, and it exhibits both direct as well as indirect immunomodulatory effects, inhibiting tumor growth. So this was a phase 3 study that was done a number of years ago. The name of the drug, again, is nadofaragene firadenovec. Difficult name. The other commercial name is called adstiladrin. And this was a phase 3 study, again, showing that 55 patients out of the 103 showed a CR in patients with CIS, again, plus minus papillary disease. You're going to see this concept of CIS plus minus papillary in most of these trials, except for the new ones. But again, when you go out to 1 year, the response rate drops quite a bit. So of the responders, half of them remained responding at 1 year. But if you really do the math, it's 25 patients out of 103 original patients. So the response rate at 1 year is about 25%. And if you continue follow up to 3 years, you see the response rate drops quite a bit. Nevertheless, this drug is very well tolerated, and it is one of the drugs that is commercially available, FDA approved, and we are definitely using this drug in select patients with BCG unresponsive disease. There's been other drug delivery systems. This is an oncolytic adenovirus, the cretostimogene grenadenorepvec, otherwise known as CG0070. It's been the subject of several clinical trials. So in the phase 3 BOND-3 trial, this was testing out the intravesical CG monotherapy for patients, again, the same population. And you can see that the response rates are now quite a bit higher than what we've seen in the previous slide. So you have 74%, almost 75% CR rate at any time. The 12-month response rate, again, drops down to about 46%, but if you do a Kaplan-Meier sort of estimate of 2-year response rate, now we're getting up into the 40% range, higher than what we've seen for any other drug. So this is a subject of several ongoing clinical trials, and the BOND 3 trial, we are continuing follow-up for these patients as well. One of the most innovative advances for non-muscle invasive drug delivery system has been this TAR-200 device. So this is placed in the bladder via a catheter, as you can see in this depiction in this video. Very easy. Obviously, everyone's used to placing catheters. But what this is basically this device that's affectionately known as the pretzel is released into the bladder. It's a small flexible wire, maintains its shape, and basically the drug eludes over time, typically 3 weeks into the bladder. And what it contains is gemcitabine. And you think to yourself, well, gemcitabine is not that exciting a drug in the intravesical treatment of bladder cancer, but as you know, it's very, very effective drug against bladder cancer, and it's really the sustained release over a 3-week period that is penetrating into the deeper layers of the bladder and delivering medicine into the deeper layers and improving the outcomes. So this was the pivotal trial, Sunrise 1. Basically, it's this device and BCG, again, the same population, BCG unresponsive, high-risk non-muscle invasive bladder cancer. Originally 3 cohorts. You can see the top 3 cohorts there. It was TAR-200 plus citrilimab in cohort 1. Citrilimab is a PD-1 inhibitor. It's a combination therapy of a local therapy plus a systemic therapy. Cohort 2 was TAR-200 alone, so just the device, and cohort 3 was citrilimab alone. So you could really see the contribution of each of these drugs. And there was, now again, this was CIS plus or minus papillary disease, and there's a 4th cohort that opened for just papillary disease. So, and basically this was dosed every 3 weeks for the first 24 weeks, and then quarterly for up to 2 years. And this is generally very well tolerated. Here's the swimmer's plot for the response rate. Again, a CR rate, which is the primary objective here, 82%. And if you do a landmark sort of analysis of duration of response, you can see the response rates are quite a bit higher than, again, what we've been seeing before. Ongoing trial, ongoing data. We've presented it several times at the national meetings, and hopefully we'll have our final publication coming within the end of the year. This does have FDA breakthrough therapy designation. You will be seeing this in the clinics, hopefully by the end of for 2024, and it really will allow us to deliver further drug therapy into bladders with non-muscle invasive bladder cancer. So this is, again, some of the response rates here. You can see the CR rate with the TAR-200 plus citrilimab was 68%. The CR rate with TAR-200 alone was about 84%. And then the citrilimab alone, as we've known with other checkpoint inhibitors in this space, is about 46%. So nothing new there. So again, well tolerated, high activity, and we're going to see this in our clinics pretty soon. Safety profile, I alluded to this. Most of the AEs are grade 1 and 2 within the first 12 weeks of treatment. Most of the patients have these irritative voiding symptoms, dysuria, urinary frequency, some hematuria, but most of these are minor, and we're very used to these kinds of side effects with intravesical therapies, BCG, mitomycin. No matter what you put in the bladder, of course, we're going to have some adverse events related to this. So this is very similar and managed with oral anticholinergic therapy or beta-3 adrenergic antagonists that help us control the bladder symptoms. Very few patients, I should go back, in the blue highlighted there, the very few patients actually discontinued therapy due to AEs. So only 4 patients within these trials. So most of the patients are just getting through whatever symptoms they're having. So there's another trial called Sunrise 3 that's in the BCG naive setting. This is, again, high-risk non-muscle invasive bladder cancer, but BCG naive. The patients have not seen any treatment, the standard eligibility criteria for non-muscle invasive bladder cancer. And 3 groups here. Group A is TAR-200 plus citrilimab. Again, The group B was BCG, the standard therapy, and group C was TAR-200 alone. So again, trying to separate out the components here. We don't have, this trial accrued much faster than anticipated. They have over 1,100 patients in this trial globally, and the primary endpoint is going to be EFS and secondary endpoints of overall CR rate. So we'll see whether this device, with or without a checkpoint inhibitor, actually competes with BCG in the near future. So there are future planned analysis for this, but it has fully accrued way faster than anticipated. Okay, so Sunrise 5, key eligibility criteria for Sunrise 5 is basically papillary disease. Everything else has been CIS plus or minus papillary disease. This is now papillary disease that's fully resected. So it's really an adjuvant type study. Same exact thing, same concept basically. You have the TAR-200 monotherapy versus this time intravesical chemotherapy or intravesical mitomycin C. So trying to see whether sustained release gemcitabine is perhaps a better adjuvant therapy option than just the intravesical gem that we put in for 1 hour. Primary endpoint is DFS, and then the secondary endpoints are RFS and time to intervention and all the standard sort of outcome measures that you can see there. This is just enrolling now, again, enrolling at a fast rate. There's a lot of interest in this device. So you're going to be seeing this, again, approved in the CIS population first, probably, and then we'll see what these other studies show to see whether they're helpful in other disease states. Okay, FGFR3, you've heard a lot about this. Mutations are frequently observed in bladder cancer. As you know, in non-muscle invasive bladder cancer, it's higher. It's probably about 60%, 50, 60%. And as you get over to metastatic disease, it's probably about 10 to 20%. We're not so sure about CIS, whether the FGFR3 status is high, as you see in other high-grade non-muscle invasive bladder cancer. We suspect it is, but we're not really quite sure. We don't have adequate studies that have been done in that space. So obviously a target here, and both in non-metastatic disease as well as muscle invasive disease and non-muscle invasive bladder cancer. So we do have to start this conversation, this concept of genomic testing in patients who have non-muscle invasive bladder cancer. There was this study, basically a database analysis looking at 700 patients, that fewer than half of these patients are undergoing any kind of testing for FGFR mutations. These are patients with metastatic disease. So I think in the future, again, we're looking at HER2 now, FGFR3 testing, so we have to get more and more familiar with testing these patients. But even in the non-muscle invasive bladder cancer space, where urologists are taking care of these patients, sending urine for FGFR3 testing or sending tissue from prior biopsies is going to be useful in the future. Instead of gemcitabine, we have erdafitinib, which, as you know, is an FGFR3 inhibitor. Instead of an oral erdafitinib, this is intravesical delivery. So there's this phase 1 trial, first in human, because it's a drug a device combination, but of course the drug itself is FDA approved for patients with metastatic disease. So cohort 1 was high risk non-muscle invasive bladder cancer, and cohort 3 is intermediate risk non-muscle invasive bladder cancer. They got 2 different doses of TAR-210, and then there was a dose expansion there. So pretty straightforward, exactly the same thing as I've been showing you with the TAR-200, except this is now erdafitinib placed inside the bladder for patients with FGFR3 alterations within their tumor. So we would send their urine and tissue, and if either one was positive, we would put them on this device, with this device. So one of the interesting things about this trial is that we left a piece of tumor behind. So we would biopsy the tumor, but as proof of concept would leave a little bit of low-grade tumor behind in the bladder so we can actually see the efficacy. And the efficacy was extremely high, 90% estimated 12-month recurrence-free survival for patients. Small trial, but again, sort of proof of principle that this is working in these patients. And the median duration of follow-up is pretty low. There's no difference in the doses, so that was for high-risk disease. For the intermediate risk disease, so which is mostly low-grade tumors, recurrent low-grade tumor, again, you're having a very high CR rate, 90% CR rate in the 31 patients at 12 weeks. Again, we left a piece of tumor behind so we can actually see whether the tumor actually disappeared or not. Durable response rates, 9 months you can see is sustained at about 89%. So very, very high response rates. And this has led to the phase 3 study called the Moonrise 1, which is currently underway. This study randomizes patients between the TAR-210 device versus investigator choice of chemotherapy. And that chemotherapy could be either gemcitabine or mitomycin, with the endpoint being DFS. So this is ongoing, and we're excited to have these trials open so that patients have an option. So one of the interesting things about this device is that this one is placed once every 3 months. So you don't have that weekly sort of installations, and it's just you placing the device in the bladder. It stays there for 3 months, and then we go and remove this cystoscopically. It takes minutes to do. And very, very safe. This is not oral erdafitinib. This is intravesical delivery, so you don't get the systemic side effects. You don't see the hyperphosphatemia. We don't see the nail changes, hair changes, and all that stuff. So all the AEs are, again, mostly grade 1, 2, irritated voiding symptoms and things like that. So BCAN has some very helpful resources for patients. This is a booklet that I use literally. I open the book and I show the patients that it has nice figures. I can describe the treatment options for the patients to the patients using these figures, and it's really helpful for them to take that home and review with them. I circle things. I put little stars of what their disease, what part of the disease process they're in. So it's very helpful if you manage bladder cancer. I really encourage you to order this booklet from BCAN, and you can download it. So I think back to you, Andrea, for...
Thank you, Sia. Thank you, Sia. Outstanding, terrific overview on the entire spectrum of NMIBC space. This is a typical patient, you know,
Yeah.
to which your advances and the advances that you have seen and you have presented with newer therapies could be delivered. A 60-year-old man with NMIBC, ECO-PS1, with CIS component in the bladder, BCG unresponsive based on FDA, well-known FDA definition that you can find again on the material that you can download on the website from the slide set. And it goes with TURBT with the evidence or no residual tumor, refuses radical cystectomy at that time. So a BCG unresponsive tumor, BCG unresponsive CIS, meaning patients who have already received at least 7 courses or more of BCG, having persistent disease or refractory disease. What are the therapeutic options that are available for this patient? What option actually would you use in your daily practice? Gem-dosi, intravesically, immune therapy, gene therapy, TAR-200, TAR-210 approaches intravesically. And in particular, I received one question of this kind: when is the case for FGF receptor testing? I would like to address to you, Sia, this first question regarding the FGF receptor testing. You know, so you have presented opportunities for FGF receptor altered patients. So when managing a patient of this kind with multiple opportunities, unfortunately only confined in the United States, so on the right side of the Atlantic, you know, much less on the left side of the Atlantic. But having said that, when would you test the tumor for FGF receptor alteration in this kind of patients?
Yeah, it's a good question. So this patient has CIS, and in general, we actually don't know what the rate is of FGFR3 positivity. And one of my research fellows sitting right there, Mazhar Zahir, is looking at this exactly. We're trying to determine what the rate of FGFR3 positivity is or alterations are in CIS patients. Typically, if we're going to test, it's going to be the low-grade tumors. Those have about a 60 to 70% chance of having positive FGFR. But since none of these drugs are actually FDA-approved targeted therapies, the TAR-210 device, it's really part of clinical trials. But we're going to be getting used to sending both urine and tissue for FGFR3 testing. So I wouldn't say it's routine right now, but we're preparing for its routine use.
Another important issue is around the AE management, adverse event. It is stunning every time to realize from the medical oncology standpoint how each single side effect may count or may be seen as differently as compared to the oncology side, from the urology side, when dealing with a patient with non-muscle invasive disease. So the 10% adverse events that are immune-related are typically managed and typically considered as normal side effects of normal routine practice, of our management. But the same events are felt much more concerning from the urology side. What is your thinking?
Yeah, absolutely. You see these percentages and you think, well, it's the same AE profile here, but the difference is that some of the AEs with the checkpoint inhibitors are permanent. You have thyroid issues, adrenal issues that lead to permanent dysfunction of requiring hormone replacement for these patients. It could potentially be fatal. In some of these trials, we have seen some fatalities. That's pretty rare, especially in experienced hands. But even though we and you as medical oncologists manage the AEs quite well with checkpoint inhibitors, we are concerned. Most of the AEs with the bladder get better over time. We can manage them with medications and they will improve. There's no true permanent damage that we see with intravesical therapies.
Thank you. Lastly, the last point is about education. I think that education is of paramount importance today, and educating the entire teamwork, not just the urologists, the oncologists, and clinicians that are at the forefront of the treatment, but the entire education and the care team, the research nurses, healthcare providers in general. And with this regard, we received a question that is addressing the need of the recharging and for how long TAR-200 and TAR-210 could stay into the bladder. Could you please explain one time again how TAR-200 and TAR-210, so the pretzel device, works in the bladder?
Yeah, definitely. So the TAR-200, again, is the gemcitabine releasing device. It's placed in the bladder once every 3 weeks for the first 6 weeks, and then after that quarterly for up to 2 years. The way it's placed, I showed you the cartoon with the animation with the catheter, and the way it's removed is we do a cystoscopy and have a little grasper that we grasp one end of it and get pulled out, just like stents are pulled out in the office. So for us, it's a very routine procedure, catheterizations and cystoscopies and stent removals. So this becomes a quite routine procedure that really takes minutes to put in and take out. The TAR-210 device is placed quarterly. So once you put the first one in, we see the patients back in 3 months. That happens to be their assessment time anyway. So we do a cystoscopy, look around the bladder, make sure they have continued CR, remove the device, place the next device in for the next 3 months. So it's quite convenient. The TAR-210 is really convenient for the patients. They don't have to come in for extra visits.
Thank you, Sia. So let's make a big step forward, or a small step forward, would depend. So overcoming the muscle layer, so looking at the muscle invasive bladder cancer, what is going on in a bit more advanced disease stage. So we do have a plethora, you are pretty much aware, I think, I'm quite sure. You are here attending GWASC, so I think that you are all pretty much aware of the ongoing, or the movement that is ongoing around clinical trials in this space. Trials that are addressing not just the one step, the pre-surgical step, but they are trying to address comprehensively the management, the care of muscle-invasive bladder cancer patients, trying to address preoperative time and postoperative period of treatment. We have a plethora of data already going out from the Niagara study. We will go into in details in the next few slides, but they are all many other trials, they are moving on the same way, putting chemotherapy backbone together with immunotherapy, or trying to shift in the landscape towards ADC-IO combination. So we'll see what the landscape will look like in the near future. Going to the Niagara study. The Niagara was a very large, the biggest study conducted in the perioperative space in these patients. So a huge effort from the investigator, patients, healthcare professional, supportive team in hospitals. Trial randomizing patients to receive durvalumab GemCis, so immune therapy drug in combination with chemotherapy, or neoadjuvant standard chemotherapy, or neoadjuvant chemotherapy followed by durvalumab in the experimental arm, or no treatment, standard of care observation in the control arm. Radical cystectomy at the center. Radical cystectomy still at the center. We'll discuss around this. At the center of the paradigm for treatment for this patient. The primary endpoint, co-primary endpoint being pCR and event-free survival. The population of patients was pretty high-risk patients. So the Niagara trial put patients with the N1, also a few patients, patients with T3, T4 stage, were the predominant population in this trial. So pretty high-risk patient population that is usually seen in daily practice in daily office. The primary endpoint was met with regards to the event-free survival. Event-free survival in this trial, including by definition also as events the refusal of radical cystectomy. So the proportion of patients who refuse, the 6% of the patients who refuse radical cystectomy were counted as events, so a very stringent, very conservative definition of event-free survival, an improvement in the statistical significant, and maybe clinically meaningful improvement in event-free survival. Improvements in OS that are statistically significant. We can discuss around the clinical meaning of this kind of improvement, but for sure it's a positive result also for overall survival. There could be issues regarding safety, and we'll go back again in the end of the presentation with regards to the safety management, and in safety and the management of immune-related side effects that are added to the overall spectrum of side effects with GemCis. It is not negligible proportion, because this implies that the clinicians that will routinely manage this patient perioperatively in the curative setting should be pretty much aware of taking care of these side effects on a daily basis, avoiding potentially delays in curative opportunities like radical cystectomy, like radical surgery. And here it comes the most intriguing point, it is around pCR. We can discuss for the entire evening, regarding pCR definition. Maybe we have not sufficient time. Sia doesn't agree. Shipa maybe yes. We can stay there discussing pCR. But again, pCR results are pretty much intriguing because they are still on the boundary of significance. Not clearly transforming with the chemo IO. A bit more, the rate is a bit higher with immune therapy as compared to standard of care chemotherapy. But there is still an issue, in particular when thinking about how to best deal with the next step and how to best deal with the removal of the surgical part of the trial. But this has to do with the future. We will discuss around this. The updates from today meeting. I'm pretty sure you have seen the updates that stands for an improvement of EFS with irrespective of the pathological response. So again, first of all, pCR as a surrogate for survival is confirmed also in the immunotherapy context. It is a good thing to do, because we do have, again, pCR as a potential screening way of new therapies in the neoadjuvant setting, and an improvement with immune therapy regardless of the pathological response in detail. We don't know exactly the detail of non-pCR, but again, the overall data stands for the improvement by using durvalumab. Intriguing results have also been presented today for special patient population. You have seen on the left side on this slide the population of patients with upper tract tumor. Very, very difficult to treat patients, very difficult to manage, very difficult to stage, very difficult to handle in a multidisciplinary setting. You know, radical nephrorectomy is the standard of care still. But the neoadjuvant Durva GEM-C is a French study, a small phase 2 French study, is intriguing. I'm biased because I'm just accepted it on JCO, but it's intriguing anyway. There are concerns regarding the limited sample size, the way of assessing pathological response, the interpretation of 14% of past CR rate with the use of cisplatin, the heterogeneity of the chemotherapy that is used, cis versus carbo. But as a matter of fact, there is data supporting a potential role for combination therapy in this patient. So a way of investing on this patient for which we do have a bad medical need. On the right-hand side, you have data from again from the bladder space, for biomarker selected patients. We're using anti-HER2 ADC, the neoadjuvant disitamab vedotin trial, showing a past CR rate which is quite higher than the past CR rate you have seen with chemotherapy backbone that you have seen before with Niagara. Potentially a bit more higher in biomarker, pretty well selected HER2 3+ positive patients. So we will see if this almost Chinese data will be confirmed on a broader, on the larger spectrum of population of patients worldwide. Going back to the ongoing trials, there are trials that are also addressing newer therapies when chemotherapy is not an option, and this is about 50% of the patient population. So trials that are addressing ADC IO, IO monotherapy, IO combinations, or newer therapies perioperatively. Again, addressing pre and post therapy, pre and post surgery option. The data are mostly awaited in this case. It is interesting to see that we have initial data moving back to the struggle between intravesical therapy and systemic therapy. For the first time in muscle-invasive disease, these are two trials on the upper side and the lower side. On the upper side, you see the Sunrise 4 data readout from the interim analysis we presented at ESMO this year. TAR-200, you have seen presented by SIA, used in non-muscle invasive disease. In this way, combined with cetralimab, an anti-PD-1 therapy, as a perioperative therapy, 4 courses before radical cystectomy in T2, T4, N0, M0, MIBC, with the past CR rate which is promising 40%, 42%. That is increasing. That is based on pretty much dependent on the clinical stage at presentation, pretty much dependent on the intensity of treatment, the way a patient can receive all the entire courses of 4 courses of TAR-200 therapy. So really promising when dealing with the way of overcoming, circumventing the radical cystectomy boundary, you know. On this slide, you see also the data from the Core 002 trial with the cretostimogene gene, so a gene therapy, intravesical gene therapy combined to nivolumab. So again, a combination of strategies showing, again, a past CR rate which seemed to be pretty much promising or higher than that presented by systemic therapy, combination of systemic therapy alone. So a promise from the use of intensification of different intensification of therapy, like intravesical therapy this way. There are also bladder-sparing options that are moving on the more classical way of using chemoradiation as a backbone, or you have initial data that are from trials that are aiming to cure the patient with MIBC by providing systemic therapy and TURBT. So, trying to change the paradigm towards the possibility of curing the patient with systemic therapy alone, basically. Are we able to cure MIBC with systemic therapy alone? Initial data from Edgalski's trial sustain the fact that clinical CR, that is now the focus of the end point of this trial, shifting a little bit from part CR that is overcome in this trial to clinical CR, a way of assessing response by using cross-sectional imaging, cystoscopy, biopsy, urinary cytology, instead of using tissue from radical cystectomy. It is a surrogate. It seems to be a surrogate, a good surrogate, like PCR did like for example, in Niagara study, for EFS or OS. It is a good thing. The initial data from a Galsky study are promising with regards to the duration of clinical CR, although the sample size is still problematic when dealing with something that can be afforded on the large scale of patients with MIBC worldwide. On the same direction, we have the RETAIN trial, just published on JCO. The RETAIN study is actually moving on the same way, providing a systemic therapy, in this case accelerated MVAC chemotherapy, RETU-RBT, and observation alone in patients who are achieving a clinical complete response. In this case, clinical complete response was assessed only with imaging, with CT scan, MRI, not with a biopsy, and this could be problematic, and for sure. And we will show you that there is a discussion, and we'll show you in the next few slides, there is discussion on the definition of clinical CR, But in this case, it's a broader definition of clinical CR, so no residual disease cross-sectional imaging, and these select patients were offered active surveillance, and the data show that there could be an opportunity for part of these patients to have a metastasis-free survival in the long run. It was a negative study for metastasis-free survival. The primary endpoint was not met, it's important to say, but there is a proportion of around 30-35 patients who were able to maintain the bladder intact in this trial. Moving the lens a bit later in the therapeutic journey, we do have trials in the standard of care therapies in the adjuvant setting. So we have struggled quite a lot, and we have worked quite a lot in the preoperative setting. It's interesting to realize that the first standard of care, new therapeutic option, let's say, in this case, came from the adjuvant setting, actually, so post-operative setting. There are 3 trials testing Atezo, Nivo, and Pembro that provide a readout in these latest years. The approval of nivolumab as a standard of care therapy by the US FDA and also by EMA with different labels, we will see, and Pembro positive data from the Ambassador study. These are almost the latest data, not the latest today updated data from the nivolumab trial to CheckMate 274. This is the publication in JCO of the trial update showing that there is a sustained DFS benefit and also OS benefit in ITT population and in PD-1 positive population, corroborating a little bit the decision of EMA to support the label of PD-1 inhibitor adjuvantly, nivolumab used adjuvantly in PD-1 positive patients. You see here the disconnection of the curves is huge in the PD-1 positive population, but also in the ITT is still confirmed as to be positive, at the long run. We had today, as I said, updates from the CheckMate study that with longer follow-up duration, showing a continuous DFS benefit with extended follow-up. So clearly, a therapeutic option in patients in particular in patients who receive standard of care chemotherapy neoadjuvantly and with the evidence of high-risk disease at radical cystectomy. The Ambassador study was also out in New England Journal of Medicine a few months ago, showing improvement on the left-hand side on DFS. There is still an uncertainty, and the data is still immature with regards to the overall survival. For sure, looking at the overlapping curves in the OS is not a good thing in general for us as oncologists, but the data is still immature. We will see if the signal would be also positive at the very long run for OS in this study. It's important to realize that CheckMate 274 was an intercontinental study. So patients included from various geographical areas, you know. The Ambassador study was a US-based study. So this could be a point to make when dealing with approvals of drugs in certain indications, you know. Ambassador study and Pembroke study actually need to be conferred on a broader patient population, a more diverse, let's say, geographically diverse patient population. The issue of immunotherapy-related adverse event is still there. So we are still dealing with the curative setting, you know. So losing one single patient here is problematic, and every one of us who has lost one single patient due to side effects in this context feel that how is problematic to deal with side effects in this curative setting. Well, we have a broad spectrum of side effects, as you pretty much well aware. You as urologists, oncologists are pretty much aware of the possible spectrum of immune therapy side effects, and in particular, the diverse timing of occurrence of side effects according to the type of side effect, meaning that the follow-up time post-surgery, it is something that has to do not just with the follow-up issue of that has to do with this in charge of oncologists, but also from the urology side, in particular in the indications in which post-radical cystectomy patients are seen both from both sides, you know, from the urology side and medical oncology side, looking on the both direction, you know, at possible and monitoring side effects from both sides is required when dealing with the long-term follow-up of these patients. As you see that there are issues like endocrinopathy or nephritis that may occur at the very long run post-treatment, in this case, for example, post-adjuvant treatment. Going back to the issue of the radical cystectomy, you know, you have seen how many efforts have been done with NMIBC, trying to overcome the refusal of radical cystectomy in this patient. But the same thing may happen in MIBC, and it is happening more and more frequently, you know, in daily practice. Patients are raising the bar for the success, asking us to have their bladder spared in the case they achieve a clinical complete response. So they say, okay, doctor, you did a good job. I have no evidence of disease in the bladder. I have a negative MRI, a negative CT scan. Urologists and SIA tell me that there is nothing in the bladder after systemic therapy. So why have to undergo surgery? Why have to move to the operating room? Well, if we have to move if we have to take any opportunity to remove the surgical part from the paradigm for treatment, we have to take really care of the data that we have today, what is actually cure for MIBC. To me, the cure means at least a 2-year OS that stands beyond 80%. Is it possible with the current standard of care therapy? Yes, we can do that. And we have seen trials and data overcoming the barrier of 80% to a 2-year OS from dose-dense and VAC primarily, from the COXEN study, from the VESPER study, and from the Durva-GEM-CIS study, not with the use of GEM-CIS. So we have discussed a lot today on the dose-dense and VAC versus GEM-CIS chemotherapy, data and significance, and the primary endpoint that are met or not met. Besides this, the data should be seen, in my view, in this way or in the similar way like this one. But most importantly, if you see how can we deal with the issue of avoiding cystectomy, so the cure with the bladder intact, and possibly the cure with the bladder intact spared by radical radiotherapy also, then here comes the issue of pathological complete response. That is important when dealing with an induction therapy that can allow you to obtain the best chances of achieving this kind of complete and deep response. And in this case, all the trials that have provided their data in this regard are below the success rate that I put as 50% at least of path CR, in order to say, okay, we are pretty much on the right path of having a therapeutic paradigm that can allow us to overcome the radical cystectomy. We may have overcome the 50% boundary with the disitamab vedotin pembro data, or disitamab vedotin toripalimab data, actually, the IO anti-HER2 ADC combination. Let's see if EV-pembro will overcome the 50%. But again, there is still much work to be done in this regard. Again, going back to a patient case, a representative case of this kind, 62-year-old athlete, so very fit patient with a diagnosis of T2, T4. So let's discuss in general of muscle-invasive bladder cancer. Good renal function, so good candidate for cisplatin-based chemotherapy. I would like to extend to you primarily and to the rest of the faculty this primary question, for the management of this patient. As an example, Shilpa, for a patient who is of this kind, who is quite fit for any kind of treatment, for any kind of intensified treatment up front, would you think that IO is appropriate treatment for this patient, or how do you manage the use of IO in a patient like this?
So right now we don't have IO approved in the neoadjuvant setting, but based on the Niagara data, we have been able to give it to our patients, gemcitabine, durvalumab, and I think for this patient, I would use that based on the phase 3 data. But I would not use IO without any other trial reading out.
Sia, what are to you the most important discussion points when discussing the entire therapeutic landscape, for this patient? Because you may discuss about many opportunities today, bladder sparing opportunities up front, or radical cystectomy opportunities, and besides these opportunities for systemic therapy. What are the main discussion points at the first patient consultation of this kind?
Yeah, good question. I think age has a lot to do with it. This is a very healthy young patient. All the data that I showed you, we're talking about a 1 to 3 year outcomes. So this is a patient who potentially has 25 year sort of life ahead of him if they're in excellent health right now. So radical cystectomy is still going to be the standard therapy with or without neoadjuvant chemo or chemo-IO. So this patient can undergo cystectomy and neobladder reconstruction with knowing that it's sort of the gold standard, and having the comfort of knowing long-term outcomes are excellent in this population. So that's how I'd approach the conversation, I think, in someone who's younger and in excellent health.
And basically, the most critical, and I think honestly, in the real world, the most frequent question is about the last one. So I have seen the entire paradigm for treatment of this patient in and outside the clinical trial shifting quite rapidly. It is interesting to see that patients are driving the decision making today, and in particular, there is a proportion of patients which is increasing who are not refusing in principle the radical cystectomy up front. They could accept radical cystectomy as an option, so not moving up front towards chemo radiation. But at a certain point in time, depending on the depth of response they achieve with neoadjuvant therapy, at a certain point in time, they question the need to undergo surgery, as I said before. So, a $1 million question to you and to you, Shilpa, how to best manage a patient that comes back to you after neoadjuvant treatment with a negative CT scan. You do cystoscopy, you do not see nothing, no residual tumor, no visible tumor in the bladder. How to best deal with this patient?
Yeah, I'll go first maybe, and Shilpa, I'm happy to hear your response. these patients are often coming to us, as you said, these conversations are being led by the patients. They're saying, the CT scan says I have no disease. Why do I need my bladder out? It's sometimes a difficult conversation, and we could do a cystoscopy and biopsies, cytology, blue light, whatever have you, to determine that state at that time. Outside of a clinical trial, I'm generally uncomfortable making that recommendation for the patient to continue surveillance because I tell them just because you're disease-free right now doesn't mean that you won't recur with muscle-invasive disease and or locally advanced disease, and we miss our opportunity for cure. So it's not a stepwise recurrence, meaning in 3 months you may be disease-free, 6 months you may be disease-free, but in 9 months you may have actual T3 disease or T4 disease. So we missed our opportunity for cure. So outside of a clinical trial, I don't recommend it. But this is more and more a common scenario. We're seeing the 25, 30, now 40% clinical CR rates with these combination therapies. And so we're going to be seeing more and more of these patients. We do have a clinical trial coming through SWOG called the BRIGHT trial led by Leslie Ballas, who, for these particular patients who have minimal residual disease or clinical complete response, they will get consolidated radiation therapy. As an option. So I'd rather do something than absolutely nothing. Of course, I was part of the GU257 Matt Galsky's trial. We do see those patients who seem to be cured, but again, these are 3-year follow-ups. We don't have the long-term follow-ups. A bladder that developed bladder cancer is, to me, a diseased organ that has the genetic changes that's susceptible to future development of tumors.
I agree with the Sia, and we also have the Alliance trial where patients get neoadjuvant GEM-CIS. Then if they have pathologic downstaging, including clinical responses, regardless of DDR alterations, let's say if they have a PCR, they could undergo surveillance or chemoradiation. If they have the alterations and PCR, then surveillance. So I think all those, because patients are refusing to undergo the procedure. So I think for this patient also, given that patient was a T4 and 1, there's a high risk of recurrence, I would counsel the patient to do something. If not cystectomy, I think doing chemoradiation, or some bladder-directed therapy would be good.
So a kind of intensification locally on the bladder, instead of doing observation alone, right? Yeah. Yeah, all these discussion point, and you were deeply involved in this discussion and the meeting that we had with the regulators from FDA and EMA in Milan in December regarding the way of defining clinical CR. So the manuscript and the report of the meeting will come out soon. But the most important point is to make to you is that in the cases that are refusing or questioning the need to move to radical cystectomy, clinical CR definition should take into account a biopsy at least, a RE2RBT at least as a first option prior to shifting the management of the patient. So first thing, doing RE2RBT, acquiring the information of what is going on in the bladder, the path CR, the path or non-path CR are set at least with the TURBT, and then moving forward with different therapies. So let's move on with the further step, and I'm pleased to introduce Shilpa Gupta, Professor of Medicine at Cleveland Clinic Cancer Center and Director of GU Oncology there, and most importantly, a good friend of mine. Thank you.
Thank you, Andre. That's the most important thing, of course. So we just wanted to give an overview of what's the updates at the meeting and what's new in the metastatic space. So we know the Javelin Bladder 100 was a pivotal trial that moved avelumab in the maintenance setting a few years ago, and more recently with the advent of EV302 data of EV Pembro in the frontline setting, that has become the new standard in the US. At this meeting, we had the long-term follow-up, which showed that the benefit of prolonged overall survival and progression-free survival is maintained, even with longer follow-up. So this is also a reasonable option for patients if they cannot get EV Pembro. And advancing treatment options in the frontline setting, there have been a lot of trials looking at combinations of chemotherapy and immunotherapy. Some of them have been negative, like the chemotherapy and atezolizumab IMvigor 130 trial was only with a modest PFS benefit. There was no OS benefit compared to platinums alone. And investigator's choice chemo and pembro in the Keynote 361 was negative for both PFS and OS, so that had not panned out. We are still waiting results for the Nile study, which is chemotherapy and durvalumab plus minus CTLA-4 inhibitor, tremelimumab. But we have since had 2 positive trials. One is the Gemcis and nivolumab CheckMate 901 trial, which was positive for overall survival. It was approved in the US last year and also is EMA approved. And then we have the pivotal trial EV302 with enfortumab vedotin and pembrolizumab, which is the unprecedented preferred frontline treatment option for patients. It has been approved in the US since December 2023, first for cisplatin ineligible patients, and then received the full approval last year. And this is the EV302 trial. As you all may recall, it was presented at ESMO in 2023. And the curves there do the talking. We don't really need to go through this. This decreased the risk of death by 53% in patients who got EV pembro versus chemo. And the risk of progression or death was reduced by 55% with that. I want to highlight here that the control arm was not optimal because avelumab was not approved when the study started, but overall about 30% patients in the control arm got maintenance avelumab, which may reflect the standard in the real world. But even if the control arm patients had, all of them had received avelumab, I think the study would still be positive. And we saw the subgroup analysis last year, and I would like to highlight that the liver metastases, which is really used to be a death sentence for these patients with metastatic urothelial cancer. Look at the activity of EV pembro, whether liver metastases or visceral metastases are present. And in the CheckMate 901, we see that it met the primary endpoint, but the curves are obviously not as dramatically separated as the EV302 study, even though we don't want to do cross-trial comparison, but that's pretty obvious. So this is an alternative frontline treatment option for patients who cannot get EV pembro. And this is the ongoing phase 3 study. This is a 3-arm study. The control arm is platinum-based chemotherapy. Only the platinum chemotherapy. There's no maintenance immunotherapy. Then there's 2 arms of durvalumab plus chemo and durva-tremi plus platinum. And then those patients continue maintenance durvalumab post initial induction. So if we look at these guideline updates in the frontline therapy, you can see here the ESMO guidelines and the NCCN guidelines. The preferred regimen is EV pembro, but as we've talked a lot at the Milan meeting, Andrea, that the drugs can get approved, but that does not mean that rest of the world has access to these drugs. I think that's a big problem, that it's not available in most of the countries, especially Asian countries and other countries out there. Europe will get access very soon. So all other regimens, including Gemcis nivolumab or Gemcis or Gemcarbo followed by avelumab maintenance, are also reasonable regimens if there's no access to EV pembro. And for cisplatin ineligible, again, EV pembro is the preferred regimen, but Gemcarbo followed by avelumab maintenance is also totally fine. It was in the phase 3 level 1 evidence. So this is the current treatment paradigm for metastatic urothelial cancer patient. Preferred is EV pembro. And like I said, if it's not available, then there's these other options. If patients progress on that, we need to make sure that we are checking their next generation sequencing on their tumors, because we have the targeted therapy or the fitinib available if they express the alteration. But platinums are by default the second line treatment that we are using. And even in the EV302, about 30% patients needed to go on second line platinum and had about 30% responses. So using platinums, if somebody wants to use erdafitinib first in positive patients, they can. If there's no alteration, then platinum is obviously an option. In the truly platinum ineligible patients, that is those who cannot get, they're very frail, they can't even get carboplatin, and obviously those are not the fit candidates for EV either. Single agent pembrolizumab is an option, And then if they improve, in their performance status with disease control, then you could use EV. But if they are still, on the borderline of being fit enough to get EV pembro, that should be offered. And the key distinction here is that, if somebody was very functional with ECOG performance status 2 and now all of a sudden has metastatic disease and has really deteriorated, becoming performance status 2 from 0, then you should offer EV pembro, because we see these patients rapidly turn around right after cycle 1 or 2. But if somebody is like a chronically debilitated patient with multiple comorbidities and baseline ECOG 2, then those may not be your best patients to get EV pembro. So like I said, if we don't check for genomic testing, we won't find it, and it's very important to do the genomic testing. And I know that also is a challenge, Andrea, in countries outside of the US. In the US, we have the luxury of having multiple vendors who can do it. Insurance covers it, and still, in the real world, less than 50% patients end up getting it. So I think we need to do better at checking because we can target that. So going over the dafitinib data for patients who have FGFR altered tumors. So this was the phase 2 trial BLC2001, which got dafitinib approved back in 2019. And that was the accelerated approval based on single arm trial. And in the phase 3 trial, there were 2 cohorts. Cohort 1, where patients who had metastatic or unresectable urothelial cancer and had prior treatment with immunotherapy as monotherapy or combination therapy, and total less than or equal to 2 lines of therapy. And cohort 2 was no prior treatment with immunotherapy, only 1 prior systemic therapy. They were randomized to dafitinib versus dealer's choice chemotherapy like docetaxel or vinflunin in Europe. And the cohort 2 were randomized to dafitinib versus pembrolizumab, because these were immunotherapy naive. So in the cohort 1, we saw that median overall survival was significantly improved with dafitinib in these biomarker positive tumor harboring patients, hazard ratio 0.64, almost a 4-month benefit. Median PFS was better as well. But in cohort 2, this was a negative trial in the sense that the median overall survival was not better if they got dafitinib first. So this trial, the message was that if somebody has not had immunotherapy, then we should give them immunotherapy first, even if they have FGFR alterations. Numerically, response rates were higher. So if somebody has more disease burden, one could think of using this first. But we have learned to manage the toxicities and be proactive about taking precautions, doing their weekly chemistry panel and checking for their nails, doing a good physical exam. So that has helped. And dose reductions are very important, obviously. So hyperphosphatemia is a key class effect of dafitinib, and it's a good idea to talk to patients about restricting dietary phosphate, upfront rather than trying to manage it later. Get a nutritionist involved, and can add non-calcium containing phosphate binder if they do get hyperphosphatemia. Ocular toxicities can be, symptomatic, especially with retinal detachment. That's why I have to be very careful, patients who are already baseline diabetics. So I want to highlight here this other antibody drug conjugate that was only available in the US based on accelerated approval. It's the TROP2 directed antibody drug conjugate, sacituzumab govitecan. This was initially approved based on single arm trial TROPHY-U01, where it showed reasonable activity in prior platinum and immunotherapy treated patients. But in the phase 3 trial, when they come in patients who had prior platinum and prior immunotherapy, when they compared this to the dealer's choice of chemotherapy, not only was it not better in efficacy, but it also had more toxic deaths. And this was withdrawn from the US market, and it never even launched anywhere else. The key here was that this drug leads to severe neutropenia, neutropenic fever, diarrhea. So growth factors were not mandated in this study, and that probably was one of the factors for these high toxicities. Another exciting antibody drug conjugate is the TDXD, which targets the HER2 And this was an important study, Destiny Pan Tumor 02, where there were a variety of cancers, as you can see, and the TDXD was used to treat these patients. They'd had about 2 lines or higher number of prior therapies. Primary endpoint was response rates. And if we look at the bladder cohort, even though it was not a huge cohort, the median progression-free survival was 7 months. And we saw higher, PFS, higher response rates in the 3+. Across all cohorts, median overall survival was 13.4 months. And in the bladder cohort, it was 12.8 months. And we saw that 13.4-month overall survival compared to 13.1 in 2+. So in the US only, this drug is available for patients with IHC 3+. Now, I will say that in the real world, if somebody has 2+ IHC positive tumor, no other options, I think it is reasonable to consider because they do have responses. And we've seen that in breast cancer, it's even used in ultra low HER2 positive. So I think depends on what we are dealing with the patient. So this is the tumor agnostic approval. It's also in the NCCN guidelines for these IHC 3+ patients. And there's also, more trials looking at different antibody-drug conjugates with immunotherapy. We saw one today as well. So the frontline metastatic disease, disitamab vedotin, which is an HER2 antibody-drug conjugate, plus pembro in HER2-expressing metastatic disease. We see here that patients, it does show activity in the phase 2 trial, and then in subsequent line therapy, also we see response rates are pretty impressive there. So the phase 3 is already ongoing in the frontline setting, but the control arm is not EV pembro. The control arm is still platinum. So I think most of the patients will be enrolled outside the US. The Dato-DXd is another TROP2 ADC in pre-treated metastatic urothelial cancer patients. We saw the update that it did show responses even in prior enfortumab and prior chemotherapy patients, also no prior EV and chemotherapy patients. So this is an important study. Tumor burden reduction was 82%. So what are the additional approaches in the third line setting? I know Sia wanted to give a shout out for the SWOG studies, and it's important, this is a cooperative group trial where patients have had no matter what, how many lines doesn't matter. They can get standard of care chemotherapy like docetaxel, paclitaxel, or gemcitabine, and eribulin. Now we are, eribulin is used very often in the breast cancer world. We don't use it in bladder cancer, but in earlier studies it has shown activity. So if you don't have the trial, but if you have it available in practices, can consider that. And back to you, Andrea.
Thank you, Shilpa. Terrific overview of the metastatic setting. A huge effort, navigating through the options. Again, most of the options that you have provided to us are seen or could be reached out in the BCAN website. Most of the information is provided for a patient perspective, but also for clinicians is useful in order to best deal with the patient decision making and the patient expectation and so on. So don't miss this opportunity. So again, a paradigmatic case for metastatic urothelial cancer is something like this gentleman, a 68-year-old patient undergoing TURBT with the diagnosis of urothelial cancer, pure or predominant urothelial cancer, presenting with retroperitoneal lymph nodes, lymph node enlargement, good renal function, and the NGS testing that was done up front on the available biopsy, on the archival tissue, showing an FGF receptor, a driver FGF receptor 3 mutation, short variant. So a patient harboring a tumor with an FGF receptor alteration, the patient undergoing AV pembro treatment, showing an initial response, maintaining response at the long run, but after 2 years of combination treatment, so quite a long time, if projecting ourselves to 1 year ago or less, it was pretty much impossible to think about this time frame. But today we are dealing with something like this, 2-year treatment with EV-Pembro, but then ultimately developing a disease progression. So what's next, Shilpa, with this patient? So EV-Pembro, not chemotherapy. This is an opportunity that is missing in most part of the European countries, but I assume it is a pretty much frequent scenario in the United States of patient failing, a patient whose disease is no more responding to EV-Pembro without being exposed to standard chemotherapy, but having in this case an FGF receptor alteration. What is your first option for this patient?
I would use platinums first, and because we are seeing good activity on patients who progress on EV-Pembro, but reserve erdafitinib for later.
Thank you.
If there was no if there was FGFR mutation.
So the point for using chemotherapy for you is still today is still to use chemotherapy, platinum chemotherapy as actually the new second-line therapy for metastatic disease.
The only caveat here, because this patient had grade 3 neuropathy, so if it is truly grade 3, then obviously we can use low dose of gem-carbo or carbo, but in this particular case, if it is grade 3, then we could use erdafitinib first and then use platinum.
And would you use platinum chemotherapy regardless of the type of platinum in this case, or
I'm
you
usually
prefer
okay with gem-carbo. I think we were pushing for gem-cis in the frontline setting, historically, but I'm not sure we really need to push for cisplatin since most of these patients have neuropathy after EV-Pembro.
Sia, going back to the pre-EV-Pembro starting, so reminding you that this patient presented with the retroperitoneal lymph node. So going back to the patient with, let's say, an inflated term, let's say oligometastatic urothelial cancer, so lymph node positive urothelial cancer with disease confined to the pelvis or at least in the retroperitoneal lymph nodes. So we have pretty good data supporting the good outcome for chemo-IO or EV-Pembro in this patient population with a huge rate of CR. Is there an opportunity for surgery, for consolidating with surgery in this case after a certain period of treatment of EV-Pembro or any kind of treatment?
Yeah, I guess two different questions here. I think one approach in this patient could have been cisplatin-based neoadjuvant chemotherapy or chemo-IO followed by radical cystectomy. It really, for me, it depends on the volume of disease in the retroperitoneal lymph nodes and where they are. If it's below the IMA, that's part of our extended template that we used to operate on these patients routinely. I think it offers the chance to eliminate any disease in the pelvis at least. I do believe these patients have micrometastatic disease, hence the systemic therapy. But this is a patient where you could manage with neoadjuvant against cisplatin-based therapy first, and then cystectomy followed by nivolumab, and upon relapse go to EV. Not a whole lot of data for that. We do have retrospective data that 30% of these patients are actually cured with surgery. For the lower retroperitoneal lymphadenopathy patients, 25 to 30% are actually cured, and that was before we had EV. Again, location matters. I encourage everyone to reach out to an expert urologic surgeon to see, are these resectable nodes. If they have extensive disease, then yes, I believe these are M1 patients and really should be treated systemically. But I think lymph nodes are very different than visceral metastases when considering metastatic disease.
See, I have a question. The 20 to 30% cure rate is in the IO setting or pre-IO?
No, this is pre-IO setting, yeah. So this is all comers actually. When you look at the patients who have up to what we used to call N3 disease, and now anything above the bifurcation is M1 really, it's lower than that. But for all N plus patients, doing a neoadjuvant approach followed by cystectomy, they do have a 25% cure rate for this.
Shilpa, would you use a different option as compared to EV-Pembro in this patient? So patient with lymph node only disease, is there an opportunity for using Nivo Gem-Cis in this patient? So looking at the long run, so this patient, you are much more experienced than myself in using EV-Pembro. So how frequent do you see a patient sustaining 2-year or IV pembro treatment? Have you ever seen this a patient of this kind maintaining treatment intensity the same for 2 years of EV? Is it sustainable for the majority of the patient? And how do you see the possibility for de-escalating therapy with treatment like Nivo-Gem-Cis, in particular in patients with less extensive disease?
Yeah, so first of all, for the EV pembro, in the EV302 trial, there was an end date to pembro, but there was no end date to EV. Pembro stopped at 2 years. So you're right, it's not sustainable or realistic. I have had a couple of patients actually who went over 2.5 years, but eventually needed a break. But I think that brings the important question that once patients have a response, it's okay to withhold doses for toxicity, no need to keep pushing EV, and patients then do well. If they have neuropathy, if they recover, then if they are recurring in the scans, you can re-challenge. So no need to keep blowing through EV. But the other point about the Gem-Cis Nivo data in the lymph node positive only patients was attractive, but that goes without saying that EV pembro is also very effective.
Yeah.
I mean, lymph node positive patients will do well no matter what, just with chemo alone or chemo and avelumab. But I think if somebody had challenges, baseline neuropathy, then we can't give Gem-Cis either. So I think if you use cautiously, the big message is that the median number of cycles was only 6 to 9 of EV. So we have to just use that information that not everybody needs to be on EV forever, and trials need to look at de-escalation.
And in your practice, what is the most frequent reason for withholding at least EV in the combination therapy in your practice?
Neuropathy and rash. Yeah.
And particularly, which is, practically speaking, for the audience, which is the driver for deciding upon making a stop in the EV treatment? What are your criteria to stop EV treatment?
So I think the key here is to make sure we're talking to the patient, doing a good history taking, because when these patients are having a response, they'll always downplay their symptoms on EV pembro, but if they're on chemo, they're always exaggerating symptoms. So I always ask the patient, I do a grip test, I make them walk, ask their family givers, and then many times patients will say, oh, we are fine, and then we hear that they're having falls and they can barely stand. So that is, of course, severe grade 3, but if patients are having trouble buttoning their shirt or holding on to things, that's grade 2, and immediately you have to withhold. So grade 2 or higher, we have to withhold, and there's really no rush to start. We've already shown from EV103 that grade 2 or higher peripheral neuropathy can take about 7 months to get better. So it really needs to be very clear that do not keep giving through neuropathy.
Thank you. And one of the last questions is about the FGF receptor retesting. So we decided to undergo chemotherapy option second line, but in case the patient developed disease progression under chemotherapy or post-chemotherapy, would you retest the tumor for FGF receptor alteration, or would you rely on the initial FGF receptor positivity?
I think I would test it again. We have the luxury to do CT, liquid biopsies for these patients, and many times we can see that initially the archival tumor may not show the FGFR mutations, but we can see it, and it can evolve, and you can still see it positive. So I would do it. If biopsy is not feasible, do liquid test.
Thank you. Another practical question. Could you remind us, you have presented the outstanding, quite promising data on HER2 targeting with ADCs in this setting. But practically speaking, how do we select patients for these kind of ADCs? Which tests are we using for selecting patients for HER2 positivity for these trials?
So we are using the immunohistochemistry test, and it is a specific test using the gastric cancer methodology, not the breast cancer methodology. So you have to ask your pathologist to run it for Enhertu treatment for gastric cancer methodology, and that's how they will do it. Because if let's say they're running it by the breast cancer methodology, if it's positive, that's fine. But if it's negative, then you may be missing out on a chance to treat the patient.
With that said, I would like to thank the friends and colleagues for joining me this evening, and thank you for your attendance, and enjoy the rest of the meeting and the evening. Thank you.
Thank you.
Thank you.
Thank you for listening. Remember to download the slides and practice aids and complete the post-test for instant credit. This activity is certified by PVI, PeerView Institute for Medical Education. This activity is developed with our educational partner, the Bladder Cancer Advocacy Network. This activity is supported by independent educational grants from AstraZeneca and Janssen Biotech Incorporated, administered by Janssen Scientific Affairs, LLC, which are both Johnson & Johnson companies. To access all materials for this activity, visit peerview.com/STT860.